Good morning and welcome all. And we'll start the first session irrespective of the audience. And this is about the corneal surgeries, the small pearls, the experienced surgeons they are going to share with us. I'll call upon Dr. Anita from Tirunelveli Aravind to talk about management of corneal trauma, the principles and techniques. Instead, yeah. Yeah.
Good morning to one and all. Special thanks to TNOA organizing committee for having me here. My title for this presentation, today's presentation, is Management of Corneal Trauma, Principles and Techniques. Corneal trauma, it constitutes about 3% of the emergency visits in our day-to-day clinics. So in this presentation, I will be referring to the principles of placing adequate sutures, drawbacks of improper suture placements, and technique of suturing. Goal of any wound repair involves aims to obtain a watertight compartment with minimal scarring and minimal astigmatism. So let us assume a 21-year-old patient is coming to you with a corneal tear. What is the foremost important thing to note? A proper history taking about the mechanism of injury, when and how it happened, and what was the mode of injury, and what was the velocity and force with which the inciting object has reached the target, and the time of injury, and any associated symptoms such as loss of consciousness, ear, nose bleeding, etc. And the accident register entry, which is the most important thing in most of the medical legal cases. It has to be entered in a correct method, and the identification marks of the patient has to be entered correctly. And general inspection of the whole of the patient, and document the facial and superficial bodily injuries, if any, and documentation of the anterior segment findings and extent of the tear, the visual acuity, pupillary response, extraocular motility, to rule out the muscle entrapments and associated injuries in the slit lamp. Posterior segment, if the wound is small, gentle B scan can be done. If not, X-ray, orbit, AP and lateral view to know whether there was a foreign body or not, and CT scan to locate the intraocular foreign body. Preoperative medications include prophylactic tetanus toxin injection, toxoid, if the patient has not received within 6 months of the injury, and topical preservative-free broad-spectrum antibiotics, cycloplegics, intravenous third generation cephalosporins. So intraoperative steps would start with doing a proper peritomy if the wound is extending beyond the limbus, assess the complete extent of the tear, and then do a thorough wound wash with removal of the debris and the superficial inert foreign bodies, and also the epithelium layer. If the epithelium, if it is an old injury, the epithelial edges from the tear areas also has to be cleaned out. And decide for whether the iris has to be abscised or reposited back. The wound edges are then aligned and then approximated. Corneal tear is repaired, and anterior chamber wash and intracameral antibiotics are given. Never ever grab or excise the corneal tissue. Never enter the anterior chamber through the wound, and full thickness bites are not safe always. And sutures, 10O monofilament nylon is used for corneal tear repair, and 9O nylon for the limbal because of its less tissue reactivity, and reverse cutting and spatulated needles because the cutting occurs in the outer surface of the needle, hence that is preferred. And what happens to when the injury occurs to the cornea, what is the topographic considerations? So to we have to learn about this, because to know the technique of suturing. The effects of injury include, whenever there is a circumferential incision in the steeper axis, it flattens along the axis and steepens 90 degrees away. Whenever there is a radial incision, it flattens the cornea in the axis of the incision and then flattens the cornea 90 degrees away. So when a suture is placed, the area where the wound is sutured, that area becomes flattened and the central cornea steepens. So the apex will move away from the sutures. So the suturing techniques depends upon the shape of the tear, whether it's a linear, curvilinear, stellate or tripartite tear. And the basic rules to start with includes If it is a corneoscleral wound, first the limbal wound is then first repaired, because the limbal palisades will give you a visual clue for the precise approximation of the other tear edges. So hence the first suture to be applied in the limbus with the nylon, and then the corneal sharp angles are then sutured, and the rest of the tear edges gets opposed automatically, and then if required suturing is done. And then scleral wound. Always interrupted sutures are much preferred than the continuous suturing. So whenever continuous sutures are tightened up, it tends to straighten the curved tear if the tear is curvilinear. So last step would be examine the wound always for the leak, and then try to attain a watertight compartment. So for a lamellar corneal tear, so first we have to assess whether it's a displaced flap or an undisplaced flap. A displaced flap will be edematous, because the underlying the nutrition to the flap is cut, so it is edematous. So it needs interface cleaning and then suturing. Undisplaced flap can be managed with bandage contact lens if the interface is clear. So how to take a suture bite? Always hold the needle at the junction of the lateral 1/3 and the medial 2/3, equal tissue on the either side, and enter perpendicular to the wound and take a 90% of the stroma. And the holding of the needle holder is also important, should not be held too tight. So how to assess whether the tear is correctly closed or not? So for a perpendicular laceration and for a oblique laceration. For a perpendicular laceration, the correct closure is then measured from the anterior aspect. That is, A and B are nothing but the distance from the wound to the entry and then wound to the exit. So same thing for the oblique laceration, it has to be measured from the posterior aspect, that is C and D, that is from the wound to the entry and the wound to the exit. So this should be equidistant. So what happens if it goes wrong? So shallow suture will cause gaping in the posterior aspect, unequal depth of the suturing, A and B and C and D are not equal, then tissue overriding can occur. So these are examples of cases which is not sutured properly. See, there is a wound gape, and the suture is not taken equally on either side of the wound. So what is the correct method of suture? That is a Rose-Hayes technique. So this technique is being proposed to attain a watertight compartment with the to attain a minimal astigmatism. So always apply a longer, deeper and tighter suture in the periphery to flatten, and a shorter, less deeper, maybe a little superficial, and shorter bites in the central to maintain the corneal contour. What is zone of compression? The importance of this is that whenever a suture is tied, it compresses some tissue inside between that. So a zone of a triangular zone is then created between the half of the either side of the suture. This zone of compression has to overlap between the sutures to obtain a watertight compartment. If it doesn't overlap, it causes leak. So stellate tears are very difficult to suture, but it can be done either by two methods, like Eisner method and the Akin method. Eisner method, it's proposed like a partial thickness incision is made between the lacerated wounds of the stellate tears, and then the suture is passed through the partial thickness and then tightened. So Akin method is that without any partial thickness groove, a suture is passed through the tissue and over the apices. If the apex is not closed in few cases in stellate wounds, or if there is a posterior tissue loss or something, a bandage contact lens can be applied, or a amniotic patch can be applied. Zigzag lacerations, it is same. This and uveal tissue management, like when the injury is more than 24 hours and the surface of the iris tissue is unhealthy and the debris could not be removed, and if there is an infection, please abscess the uveal tissue. Deposit back if the injury is less than 24 hours, it's a healthy surface and clean wound. Remove always the epithelialization over the wound, and cataract is managed in every case will depend, it differs. And suture removal has to be done at 6 to 8 weeks in children, 2 to 6 months in adults, and loose sutures have to be removed and avoid corneal vascularization. Last slide. In special conditions, the corneal trauma also may require a corneal transplant in case of extensive corneal tissue loss, post-classic injury, lost flap, and post-arc injury, and a trauma to a brittle cornea. This is the case of a fish hook injury, which we have retrieved out the fish hook by doing a cut it out technique. Thank you.
Me. What ma'am?
Yeah. Thank you, Dr. Anita. You touched upon all the fine points in managing corneal trauma. Now I call upon Dr. J.K. Reddy on the management of astigmatism in PK. We'll have the question session later.
Yes. The keratoplasty is doing surgery is not a big thing. It's a astigmatism management. Uh, Keratoplasty surgery is not a big thing. It's in a few months we can learn, few weeks or months. But managing the astigmatism, otherwise the patients won't get in vision. We will have a clear graft. That is the biggest problem. We need so much time to learn it. So even after 30 years, I am not able to learn. I don't know how I can explain in 7 minutes. There are three components here: the preoperative, post-operative suture related, and late post-operative. After you remove sutures, wait for some time. The wound modulation keep on changing. They become ectatic, or if the wound is good, very strong, then still they will have a residual astigmatism. So there are three components in this. Preoperative, we have no control. Sometimes like a hydrops, a keratoconus case or PMD case, they have pre-existing astigmatism. In that suturing all will result in inevitable result in some astigmatism. That need a very specialized planning to prevent that. Then size, shape and centration. They are the other things which decides astigmatism. That defines, that means, I mean to say, the quality of the, right, only the size, shape and centration, the quality of the defines. Larger the graft, less the astigmatism; smaller the graft, higher the astigmatism. But we cannot do a very small graft because there's an issue, or very large graft is a problem. So suturing technique also plays role, but among all, suturing technique role is very limited. There is a role, but the other things are more important. So in peroperative, what we do is we put a keratoscope. What we are doing to control astigmatism for the past few years, we put a keratoscope. That's a 200 micron cycle of LED light. We put it. Then we adjust the suture. On the table, you are okay. You can bring within 4 diopters of astigmatism by this, because it's very subjective. 3 to 4 diopters of astigmatism on the table with the sutures on. What happens after that, we don't know. On the table with the sutures on, we can adjust sutures and bring a nice round light. So that the astigmatism, immediate post-operative vision, patient will have good vision, reasonably when compared with the other techniques. Same thing we can do with interrupted also. So whichever suture is tight, wherever there is a flattening, that means instead of going round, it is going straight. That means this suture is tight. We don't need to remove. We just pull it, stretch the suture, remove it, stretch it, it will get ovalized, round, it will become round. So whenever it is prolonging, I mean becomes oval vertical, means that sutures are loose, that we have to replace. So the shorter axis, it means if there is a oval like that, then you have to do tightening release. That's how we do it. Sometimes we replace, most of the times we adjust it by pulling the sutures and pushing and putting. But this advantage of the keratoscope is on the spot we can do it. Okay. Then post-operatively, how you use topo-guided suture removal. For example, this is a case. If you see keratometry, it will show this axis is steep, this axis is flat. The blue side is flat and the red side is steep. But if you take a topography, you have more information. You cut off one suture here, you cut off one suture here, and you try to remove here also, it's very steep. Remove one suture here, so it becomes more regular astigmatism, and try to do that. Like that, that way the topography helps in doing a suture removal than keratometry. Then last post-operative period, that is wound relaxation incision. What is PRK, LASIK, phakic IOL, piggyback sulcus IOL, and pseudophakia, and toric IOL. So all we do. As for example, this is the case. We had irregular astigmatism and ghosting of images. If you look at the reflex, these are all okay. This side it is flat. There is no curvature. So here it is steep. So this is a case of dark. So we are relaxing the incision with perioperatively, I mean on the table, operating table, by attaching keratoscope and under topical anesthesia. So we are opening the wound at that area. We are not making any special incisions. We are just opening the wound at that area, junction, corneal recipient donor junction. We have to open it slowly and deeply. It can be easily be done once. It will be a little bit tough, takes some time. 10 to 15 minutes it will take. It won't get, they don't come out so easily. So you keep on doing it until it becomes, that flat area becomes little oval round. So once you get a reasonably round, you are satisfied, you leave at that point and put them on antibiotic and steroids. You don't need steroids, just antibiotic, bandage, contact lens for 1 month, then they will settle down well. This is another case. If you see it, if you see at this level, this is very long, this is very short. So that means here and here, it is the cornea is steeper, this axis. So we are relaxing wound gaping. We are doing it both inferiorly, this angle and this angle, and inferiorly and superiorly. There is extent to which we can do, but that's okay. Some amount of 10, from 10, 12, we can bring down to 5, 6, manageable level. And it works very well. We are doing even 10 years back operated case also. For example, this is the pre-operative, is almost having 10.7 diopters of astigmatism. This is the post-operative. Patient has come down to 0.6, almost nil. But the problem here is there is a lot of triphyle and quadriphylls here in the central. They do have some ghosting and glare, but the total visual acuity will be much better than before. This is the comparative map. So we are able to reduce almost 7.5 diopters of astigmatism in this case, but we got effect of almost 10 diopters of astigmatism. So this is another case. Well, this is a very nice, symmetrically bow tie and a very nice place. But if you look at astigmatism, 12 diopters. 12 diopters on the cornea becomes almost 14 diopters in this particular acceptance. We can make a ICL and put for this patient, but we thought, okay, let us reduce, and with the suture relaxation, the patient has come down to 4 diopters now of astigmatism. We removed and relaxed the sutures. This is the difference. We are able to reduce 7 diopters of astigmatism. This is a PKP case, this one. So there is a question whether PKP cases do it, the wound becomes leak, descends, and pressure, they may open up. There are so many questions, but we have to do it to know what happens. Without doing, we can never know what happens. So we have to do it. There is no other way. This is the phakic lens. They do very well. If you have a symmetrical astigmatism, we do a lot of patients phakic lens. And thank you very much.
Thank you, Reddy. That's a very comprehensive and short, but quite a difficult topic also to handle. Managing post-keratoplasty astigmatism is not as simple as what Reddy shows. Maybe it's very simple for him. And many times some irregular astigmatisms are a really big headache with very nasty scars, very difficult to manage. In Dr. Anita's talk, any questions anybody would like to ask?
I have a question. And see, the primary non-corneal surgeons, okay, the suturing, which are not trained in long-term, short-term, the biggest problem is, or budding surgeons, fellows, they go corneal tear suture, you give it, they will do it. What advice you give them to prevent the deadliest complication of corneal surgery, trauma, is iris cyst. The deadliest is iris cyst. What specific? If once iris cyst comes, that's the end of the impossible. I have to send to Srinivas Kera only. I don't touch. He will do so many things. He will remove entire iris, ciliary body, and reconstruct. I cannot do such a destructive surgery. And what advice you will give to prevent iris cyst? Whatever way you suture, it doesn't matter for me. Anyway, I can put a graft, I can put a scleral contact lens and make him see. But once iris cyst starts, I have to keep watching only like a movie. I don't do anything.
It occurs mostly due in cases of old injuries, and also due to the epithelial downgrowth from the edge. So avoiding epithelial downgrowth during tear repair is foremost thing, which I mentioned in the talk also. So removing of the epithelium from the epithelial edges, and also over the iris. So thorough cleaning you have to do. If there is the epithelium can't be removed, better the iris can be abscised to avoid all this. Because I had a patient, young patient, as sir said, there was a limbal wound and there was iris was formation, and even after the managing the iris cyst, everything was very difficult afterwards. Even after the excision, everything, patient had a secondary glaucoma, and the eye went for phthisis only at last. So adequate, you have to definitely do that wound wash and epithelial removal from the tear edges, and well beyond the tear margins, the epithelium should be removed and then thoroughly washed. That is the prior.
Limbus one, as you told, is exactly. It looks very nice. Limbus, you put a suture, but there will be small fistulous gap. The sclera will retract. So from there, they say it's a limbus. From the limbus, keep on growing epithelial cells. Cornea, it's okay. We can see very nicely. So put a very tight suture at the limbus. Very more than necessary. More than necessary. Put a tight suture, the horizontal suture. It doesn't produce any astigmatism, limbus suture, because it's radial. So put a very simple tip, put a tight suture. Then for visualizing epithelium, I tried a trypan blue. Just put a trypan blue on the table, wall wounds. It's getting coated, and leave it for 2 minutes. Epithelium is somehow it's getting. Then you will have a better one to peel off from wound edges and from the iris. But once it starts, you remove the cyst, it's open. You are not removing, you're opening the slip. It will go.
It's more of glaucoma than thysical. Secondary glaucoma associated with that, and the chronic cells will be there always in AC. It's not exactly uveitis or anything, but the cells will be there always, and patient will be highly symptomatic. And another reason for that is the ragged iris. If it is too much damaged, revitalized, it's better. Don't try to push it in and try to keep the iris in, and better to abscise and do the thing. Especially in children, this is very common. They go for iris cyst very fast. Thank you. And about the next talk, about Dr. Reddy's talk, any questions? Anything? Bhaskar or somebody? Yeah. Any comments?
I will first ask a question. Most times, like Dr. Reddy said, that when you have a novice who's doing trauma repair, they tend to have a problem with the fish mouthing of the incision, especially if it's a radial tear, and it just doesn't close. So if you have to put, say, a drop of cyanoacrylate glue, could you just mention the technique of doing it so that people don't spill the entire glue on the surface of the eye?
So, gluing of the, sir, you mean the stellate? For better, like the stellate wounds, it's better to put a contact lens, and if gluing is necessary, the epithelial edges have to be cleaned, it has to be dried, and with a wet, I usually use a wet sponge, the blue end of the wet sponge, and then put a drop of glue over it and put a bandage contact lens over it. And usually what otherwise I do is take a longer bite and then do a closure, like a mattress suturing also can be done to close the stellate tears.
We also try the fibrin glue with bandage lens. Dr. Anita used to do it often.
And the other thing was with respect to iris cyst, the problem is when the cyst is small, we don't want to touch it because the vision is good. And if it grows larger, then you end up losing the eye. So whatever be the risk, if it's a small cyst and it is an iris implantation cyst, you have to go ahead and either surgically excise it, or you can use agents like alcohol, which has been reported. The worry that we have that there can be a spillage of the alcohol inside the eye. If you do it properly, the success rate is close to about 60%. It's not 100%, but it's about 60%. We've done close to about 30 eyes, 35 eyes so far over the last 10 years. You might have to repeat it in a couple of times, especially in larger cysts, because you are not able to coat the entire cyst wall with the alcohol.
You inject alcohol? Or?
Inject alcohol.
Okay.
So you can use the trocar cannula, the VR trocar cannula. Only thing is you make the projection of the needle only just so that it goes into the thing. So you have the trocar there, 27 gauge trocar. Use the 26 cannula. So you are the worry that we have when we are injecting is it shouldn't go into the anterior chamber. It shouldn't cause a counter puncture of the cyst leading to the rupture. So you place the trocar, then it's more comfortable for you to aspirate, and then you inject alcohol, wait for about 30 seconds, you see a whitening of the wall, and then aspirate it off, wash it a couple of times so that the cyst comes out. If it recurs, you can again repeat it, but every procedure, if you are repeating it, you will expect some kind of endothelial loss. Be ready with your phaco machine, because in the moment you see there is a leakage, then you have to go in and aspirate it out. When you are aspirating the cyst, look for chamber collapse. If your chamber is collapsing, there is a communication of the anterior chamber with the cyst, in which case you will not inject the alcohol. You will then have to look at using argon laser or surgically excising the cyst.
Yeah. We tried the 5F uracil.
5F, mitomycin, visibility doesn't give you,
alcohol
gives you an idea that it is a different viscosity as compared to 5FU or mitomycin.
Yeah. Thank you. the next talk. I think Dr. Anand Parthasarathi is not there, so instead Dr. Ramya will be presenting the talk. Yeah.
I have uploaded in the preview room. See, this one I think. It's there here. Dr. Anand. Yes. Good morning, everybody. Unfortunately, Dr. Anand Parthasarathi could not be with us. This is his presentation that I'm privileged to present here. A few pearls for hydrops and descemet membrane detachment. So this is a case of an advanced keratoconus patient that a DALC has been attempted for. And you can see that there is the air bubble injection has caused a type 1 bubble. And when you want to see the extent of the bubble, you can put a small air bubble inside the anterior chamber and look at the delineation of your type 1 bubble. This is what he's using the second bubble for. And once you've made out the extent, then you can go ahead and do the brave slash. Now when you incise the posterior stroma, your small bubble should come to the center because your big bubble has gotten released. And you can see the bearing of the descemet membrane. Some people like to use visco at this step. But once the big bubble releases, the small bubble comes to center, so that is a visual clue. Then you can go ahead and excise the posterior stroma. And this case had a vision of 618 to 612 post-op. So this is OCT of a peripheral descemet detachment. And if you have a very peripheral detachment, especially when your entry wound in your phaco is probably a little blunt, you can actually observe those cases. You don't have to do anything immediately. It's quite common. This is again a 12-year-old patient with a sudden drop in vision, and this is a hydrops. And when you look at the OCT and you see these multiple fluid clefts, then the ideal thing would be to do compression sutures. We used to give hypersol eye drops, hypertonic saline, and air injection also. Those are options. But when you have multiple fluid clefts, a compression suture might work better. This is a video of Dr. Sunita Chaurasia's where first air is injected and then compression sutures are taken throughout. These allow egress of the fluid and allow the hydrops to heal faster and for earlier visual recovery. Then you put a bandage contact lens on top. And usually if you give hypertonic saline, you have to wait for a very long time. And then after that, you can plan the patient for a contact lens. This is the immediate post-op where you can see the fluid clefts are gone. And this is the first day post-op of the same patient. So the pulse is, you look at the time of the descemet membrane detachment, whether it's intra-op. If it's intra-op, you look at the extent. If it's early or late, you look at whether the visual axis is involved, and you always do an ASOCT and delineate those areas of the detachment on the ASOCT in a sheet. Take that sheet with you to the OT and remember to invert it because you're seeing an inverted view in the operation theatre. A nomogram for management of hydrops would be conservative, where you put the patient on steroids to reduce the inflammation, hypertonic saline to reduce the fluid inside the stroma. Surgically, you can go desmetopexy with air C3F8 or SF6. You can do an air tamponade. You can do a suture fixation, a desmetotomy, or you can go ahead and do a keratoplasty. If you have a peripheral detachment when you're doing your phaco, there's no need to panic for those cases. Larger detachment, look at the swelling site, look at the tamponading agent, can be SF6 rather than air. And surgical principles of a descemet membrane detachment is you ideally want to go from the attached area. You want to put your needle through the attached area and then go and inject air so that the unattached area goes back and attaches itself to the stroma. So for that, you need to know which area is unattached and which area is attached through your ASOCT. That's why it's better to mark that. Here, this is a video of Dr. Vikas Mithals where the intraop OCT is planned for a desmetopexy. So the port is made at a site away from where the desmet is detached. So it's very important to know that. And then you go and you put a single air bubble, a large single air bubble, and full chamber of air is injected so that it actually pushes the detached area back. So this is a picture of a patient with desmet membrane detachment and post-air injection, how it clears up. And usually, even if it is a slightly later period, it is always better to try an air injection before deciding to go in for a desmet membrane endothelial keratoplasty. It's always best to try and see if you can actually attach the desmets and if it works. Because as long as the desmets is still remaining in the aqueous, it doesn't get damaged so much. So it's always best, even for a 3-month detachment, to try an air injection or a SF6 injection first, and if it fails, then you can go ahead with an endothelial keratoplasty. So the take-home pearls is preoperatively assess it and decide if you're going to wait or you're going to go in for a surgical technique, and plan it preoperatively. Post-op management, especially post-air injection, you need positioning, has to be explained very well to the patients, and you may need to take it up for a secondary procedure or repeat injections. Thank you.
I thank all my speakers so far who are finishing well ahead of time. And it's a very important point what she mentioned in case of desmet membrane detachment, post-cataract and all. The membrane is intact. It's better to wait and still attempt a repositioning before writing it off and going for a DSEC or DMAC surgeries, because many times these desmet cells will be, endothelial cells will be still viable. So you repose, there's a chance for it to get cleared. But if it is in multiple tears or anything, then it's very quite difficult even to repose and keep it in place. It can recur again and again. Thank you, doctor.
Thank you.
And we'll move on to the next talk. Huh? Yeah.
You mentioned making a side port away from the area of the DMD. It's also important to start the air injection from that particular side port, but as the bubble expands and pushes the DM against the endothelium. Otherwise, if you go into the center and then put in the air, you will have another tear you will have. The other point that perhaps can help is if you have a tear with multiple folds, what you can do is that you keep injecting saline until finally the DM again finds its orientation, small flushes of saline. That helps too.
Especially rolled one, scrolled one, quite difficult. First you unscroll, float it, and then repose. Yes, Dr. Bhaskar.
And your visibility, intraop, you could probably use light pipe to make sure that your orientation is correct. The moment you put in an air bubble, you will actually see the edge kind of oppose well. If the DM attaches within a couple of minutes, you will start seeing epithelial edema being unmasking because the stroma has started to clear off. So that tells you that your DM has reasonably well attached.
We also use glycerin, autoclave it, and before surgery also on this thing. After repositioning also for few minutes, if you use it, it will attach very well. Can you come to the mic, doctor, please?
Any indication for considering SF6 versus air?
Yeah, if it is a large one going up to the inferior part, because you put with the air, sometimes the air will get absorbed by second day itself, it will go up. So, and especially if the DMD is in the inferior part mostly, then your air will, once the air moves up, again you may get redetachment. So in such cases, we can use SF6.
So any Trendelenburg position you would?
Generally, we don't know. We advise them to be in supine position for the day, and also try to do a PA.
Thank you.
Not so necessarily an inferior PA, some PA at least we can do.
I have stopped using SF6 for DM detachment purely, treat it like how you would treat a DMAC. The important thing is to have a full large airfare for about 2 hours or so, and you can decompress it slightly, and that to a large
Yeah.
extent does it. If your cornea is otherwise healthy, if you have
Yes.
a Fuchs dystrophy patient with an unhealthy endothelium, then yes, then you might and still require it. The second point is early post-operative period, the air sometimes doesn't stay because your side ports are leaking. So
You have to suture.
On table, you get a full fill, but when you see in an hour's time, you see the air is already smaller, and those are the cases where you actually end up having a repeat detachment as such. So if there's any leak from the side port, make sure that you suture it and get a good complete air fill, and that should to a large extent solve your detachment.
Yeah, it's better uniformly you suture always the side port. That's true.
What is your preferred choice, sir? If you have a Descemet membrane detachment and you inject visco, sometimes it's common in early cases, you inject viscoelastic and then it goes between the Descemets and the stroma and you have a complete DMD. And there you actually have to remove the visco before you inject the air. So how do you...
Refer the patient somewhere else. you will have to inject saline, you will have to depress that area, and you will have to aspirate the visco as much as possible. You will actually induce a little bit of a detachment, because unless you get the visco out, the DM is not going to attach.
While seeing that video, one very small point, madam, where it happens to all of us, but where when we ask for air, the sister removes the saline cannula, puts it in the air cannula and gives it, and that's when you get these fish eggs very often. And especially for high drops, if that small bubble goes into the interface, then it can be a nightmare to remove it. So.
Yeah, now I call upon Dr. Shreyas for customized CXL.
Thank you so much, madam, and thank all the organizers of this TNOA conference for this opportunity. So today I'll be talking about this not very often spoken topic of customized CXL, and I'll try to take you all through the rationale as to why a customized CXL could work better than a regular CXL, and a little bit what goes into the planning, and also show some of the initial results with this procedure. So customized, essentially, keratoconus starts off as a focal disease, and whether greater energy delivery or greater fluence over the cone can give us better results. This came about from early Brillion microscopy studies, which showed that while imaging Brillion studies from the center to the periphery, where you go into different parts of the cornea, it was shown that the region of the cornea outside the cone in keratoconus had a Brillion microscopy shift which was similar to that of a normal cornea, indicating that the tensile strength outside the cone is possibly similar to that of a normal cornea. Also, computational finite element analysis showed that giving a greater amount or selectively inducing stiffening the weak area flattens that region of the cone, and thereby giving a better regularization and improving the visual function. So, while this was there in theory, this was made possible by the advent of the KXL2 system from Avidro, where you can customize these energy patterns and make them in different arcs. And most importantly is the availability of the pupillary tracking, because it is in relation to the pupil that you are going to decenter the different zones of energy treatment, and having an active pupillary tracker is important in the CXL device. You can have various patterns, sagittal patterns, you can have even a freehand diagram, you can have concentric circles. But the basic premise is that the maximum energy goes over the area of the maximum steepening, so that you are trying to induce a selectively greater amount of flattening over the apex of the cone, which goes on reducing as you go on to the periphery. You can center it on different areas. It could be based on the sagittal curvature, you could base it on the pachymetry, but what we found most accurate was using the maximum of the posterior float, because both pachymetry and sagittal curvature can be influenced greatly by the epithelium. And as we all know, the epithelium is a masking agent in keratoconus and can alter the picture, whereas the maximum of the posterior float is not as affected, and therefore that using that as the central point over which the energy zones are delivered seemed to be the most accurate method. You could vary the diameter of the circles based on the size of the cone, and you can use the X and Y coordinates. The reason why we use these X and Y coordinates is because we are going to decenter the treatment from the center of the pupil on the CXL system based on these coordinates. And there are various formula which have been used. Either you can customize it to the size of the cone of each patient, or you could have a fixed 3, 5 and 7 millimeter of concentric circles. In case you're customizing it according to the diameter of the patient's cone, then basically we are using the shortest and longest diameter of the cone on the posterior float and adding 1 millimeter to it, and that's how we are basically identifying the size of the maximum central zone of energy. Like I said, the X and Y positions can be adjusted on the system, and you can move around the location of the concentric circles. Maximum energy in the center goes on reducing as you go out, and as you can see, the time duration also keeps reducing as we go out. So just showing some of the initial results comparing customized CXL with standard CXL with a minimum follow-up of 6 months. This is just to show the baseline data was similar across both the groups. In the customized CXL group, you can see that the extent of ISA symmetry, the amount of flattening of the K-mean and K-max were all statistically significant. BCVA, while approaching significance, did not really reach a significant value. Whereas the same amount of improvement in ISA symmetry or K-mean or flattening of the K-max, we did not achieve with the standard accelerated CXL protocol. These are some just images of patients who underwent customized CXL. As you can see that there is a significant improvement in the ISA symmetry down from 7 to 1.4 diopter. There is excellent flattening of the cone, and this is without haze. You normally see these in standard CXL when the patient has haze, so it's essentially scarring which is causing the flattening. But whereas in these customized CXL cases, you get this kind of results even without a resultant haze. And this is another patient again where you can see that the central area, the central 3 to 5 millimeter zone, the symmetry is significantly improved. The flattening of the K-max, you can see in the custom CXL group in the red columns that a greater amount of patients had more than 2 or 3 diopters of flattening as opposed to the standard CXL. And in comparison between the intergroup correlation, you could see that the amount of delta ISA symmetry as well as the K-max was significantly better in the custom CXL group than it is in the standard CXL. The demarcation line also in the early post-op 2 weeks, 3 weeks when you're imaging these patients, you can see at different levels. One superficial in the most periphery, a little patchy in the middle, and the deepest central, most deeper demarcation line, which all of these tend to disappear over the course of the next 2 to 3 months, as it always does in the regular CXL as well. But this is something which you see in the early periods and indicative of different levels of cross-linking at different zones. The endothelial counts were stable across all the groups. The haze formation was also comparable to that of standard CXL. So essentially, by giving these kind of predictable patterns, we get more predictable results, or probably augurs for better refractive and keratometric outcomes. And the future would be augmenting this with topographic guided treatment as well, where you could combine the effects. There is already a paper out from John Kanelopoulos where he has combined customized CXL with topographic guided treatment and shown superior results to that of standard treatment. Thank you so much for your kind attention.
Thank you, Shreyas. If you stay back so that we'll have the discussion after the next two talks. Now I will call upon Dr. Sumati on CARES.
Good morning. I thank the organizing committee for giving me this opportunity. This is a financial disclosure. CARES stands for Corneal Allogenic Intrastomal Ring Segments, wherein allogenic ring segments are placed intrastomally to treat the corneal ectasias. This procedure was described by Susan Jacob in 2015, and we have been using this procedure for treating keratoconus since then with good results. These CARES segments can be harvested from the donor corneal button, and you can actually prepare the tissue when you are doing your procedure, or you can use a pre-cut tissue as any other stored donor corneal buttons. So initially when we were doing, the segments were of uniform thickness and longitudinal, and by customizing this segments, we can actually refine our results, and in terms of your thickness, arc length and shape of the segments, so that you are tailor making the segments for individual patient based on the topography of the patient, so that you get a more regularized topography post-operatively. So we have know that the synthetic segments have got good results, like with asymmetric or symmetric segments. When we were using our longitudinal uniform thickness segments, we have got good results in almost all parameters of the parameters post-operatively, be it improvement in the spherical equivalent, or improvement in the uncorrected or best corrected visual acuity, improvement in the keratometric topography, or K-min or K-max, or even the best fit sphere. But with even this, we thought, why not customize these segments so that we can actually design the segments for the patient. So believe me, we can change the arc length and the shape and the thickness and the width according to the patient. So you have your patient's topography in front of you. You customize the segment based on where you want to have a maximum steepening, where you want to have a less steepening. Accordingly, you design your segment. So thereby tailoring your procedure for each patient. This is an animation showing the customized cares, where a double-bladed refine is used to punch the donor graft, and the harvested material is cut into two halves, and then it is placed on a degree zone marker, where you are placing marking your arc length and the clock hour where exactly you have to start your customization. Once that is done, then you are placing the segment into the intrastomal channel, which is created by the femtosecond laser, and you can compare that with your preoperatively designed topographic pattern. And customization can be of any type, like it can be a symmetric segment or asymmetric segment, or like it can be of progressively reducing or increasing thickness, or progressive increasing or reducing width. The transition positions can be even as low tapering or a sharp edge tapering, or you can have a localized tapering, or you can have a tapering all length along the arc length of the segment. So this is actually followed by the collagen cross-linking, either conventional or contact lens assisted collagen cross-linking based on the corneal thickness. This is an actual procedure which we have done on a patient. After refining with a double-bladed refine, we mark the Bowman's side of the segment and cut the segment into two halves, and then place it on the degree zone marker. This degree zone marker, we have it, you can have it in a computerized one, or it's in an autoclavable degree zone marker. Here this degree zone marker actually has all the clock hours as you see it in the topographic map, and also the zones like 3 mm, 5 mm zones and all. And then you mark the care segment which you have designed preoperatively. For example, in this case 445 is the one clock hour which the segment starts, and 715 is the marker, like where you start tapering your segment, and the ending at 915 clock hour. All these things you are designing preoperatively, and accordingly you are placing the segment on the 5 mm zone, and then marking your segment with your marker pen. Once that is done, you design your segment and go to the patient. So after marking the CSLR, and you can actually mark the clock hours on the patient too, 445, 715, and whatever the clock hours you had marked on the care segment. And then, using a femtosecond laser, you would create the stromal channels. And then the segment is placed into the stromal channel using a curved wire rod. And then you can compare this with your preoperative topography pattern map also. So being a allogenic material, the segment gets very well integrated within the corneal tissue. So most of the problems which you can see with the synthetic segments in terms of extrusion or stromal melt or infectious keratitis or match, we haven't seen much cases like this. And in cases where the keratometric value Kmax is more than 58, or the corneal thickness is less than 450, or when the scotopic pupil size is more than 6 mm, you actually synthetic ring segments are usually not preferred. In such cases, we do have done CAS procedure with getting a better results. And allogenic material, being it an allogenic material, this segment can be used in variable thickness, and even a superficial placement can also be placed, so that we're getting a better effect. But with the same thing cannot be expected in cases of your synthetic segments, where you can have a chances of your melt or extrusion of the segment. In cases where even the optic zone is less, like maybe even in 4.6 zone, like post-operative glare and halos are not much in case of customized cares. So
these segments can also be used in cases like extrusion or melt. So these segments can be designed in the same size of your intact segments, and either, well, if it is an migrating, then you can actually suture the one end of your intact segment to the care segment and railroad it along the same channel by opening the opposite end, so that you can preserve the same synthetic segment result which patient had preoperatively. Usually in such cases you just remove it and leave the channel so that the cornea heals by itself, so that the patient loses the postoperative vision which he had already had it. So this is one more advantage where you can use the care segment. This is a double-bladed refine, which we have it in 3 different sizes. By altering the inner and outer diameter of this rings, we can actually change the bulkiness of the care segment. There are studies like where we are using femtosecond lasers to create the customized cares. By femtosecond laser, maybe it might be the future, like where you can have a real customization in terms of your exact arc length and the designing of your care segment. This is another technique where a jerky technique described for when dehydrating the cornea and then inserting into the intrastomal channels. And synthetic segments are actually available in a fixed arc length and thickness, and one end might be a fixed tapering and things like that. But with the cares, actually we have a multiple option, like you can decide your arc length, you can decide your shape, like it might be a one-sided tapering or a double-sided tapering, or you can have a tapering can be even a broad edge or a narrow edge, or like you can have a double-sided thick segments connect with the connecting band. All these shapes, like you can customize to the patient's topography in your hand. So you are designing the care segment for your own patient. That is how you are tailor making the procedure for your own patient. So to conclude, I would say, like even in cases where combined with collagen cross-linking, we have avoided DALK in many patients too. So conclude, I would tell that customization of gives you a much more tailored planning, and then you can design your treatment for your own patient as according to the own topography also. Thank you.
Thank you, Dr. Sumati. It's a very appealing idea and nicely portrayed. We'll move on to the next talk, Dr. Divya. And Dr. Sumati, please stay back so that we can have some discussion if possible at the end. Divya is going to talk about the other newer thing, DVEC.
Good morning. So I'll be discussing about descemetorrhexis without endothelial keratoplasty, and also called as DSO or descemetor stripping only. So as we all know, this technique is most commonly done when we have a patient with Fuchs endothelial dystrophy, which is a slowly progressive non-inflammatory condition which causes corneal endothelial dysfunction. In the initial stages, patient can present with epithelial edema, blurred vision, colored halos, and glare. When the disease becomes more progressive, a patient presents with stromal edema, corneal decompensation leading to scarring, and also significant defective vision. Initially, it is treated medically with hypertonic solutions, and the later stages, we can either do a DSEC or DMEC surgery. What I'm going to discuss today is about DVEC surgery, which is descemetorrhexis without endothelial keratoplasty. So we did this during COVID when there was dearth of tissues, when we didn't have enough tissues to do endothelial keratoplasty surgeries. We went ahead with it, and we also used ripasudil for these patients. Why ripasudil? Because it's again a serine or a 309 protein kinase. So it kind of regulates and modulates the cell shape and size through the action on the cytoskeleton. So it is 0.4%, which is commercially available. It is mainly used in the treatment of glaucoma and ocular hypertension, and also has off-label use for corneal cell endothelial cell proliferation, and it also reduces apoptosis. So so basically there is cell proliferation and promotes cell addition onto a substrate, and also suppresses apoptosis. So this is why we use ROCK inhibitors. And so our patients were patients who had to undergo cataract surgery. So with grades 1 to nuclear sclerosis grade 1 to 2, and who had a central corneal thickness of at least 600 and above, and best corrected visual acuity of 660 or better. And it is good to have patients who have a central focal localized guttae and not throughout the cornea, because we need the migration of the good cells from the periphery. So it's good to have patients who have central cornea involved, or at least a focal cornea involved. Again, best corrected visual acuity, clinical examination. ASOCT is done to look for the central corneal thickness in the preoperative stage, cataract evaluation. So technique is very straightforward. It's a very simple technique, and surgeons who are already doing DSEC and DMEC, it's just a walkthrough for them. Under topical anesthesia, we do phacoemulsification followed by a 4 mm of central corneal desmetorexis. The reason again, we want the cells from the periphery, the good cells from the periphery to migrate towards the center. Post-operative medications are what we follow for regular cataract surgery. And in addition to that, we start the patients on Repasseril eye drops 4 times a day for a minimum of 2 months or until the cornea clears. So under topical anesthesia, or this patient was done under block. This was our first patient. So phacoemulsification surgery is being done. So we do the cataract first, followed by desmetorexis. We've increased the speed. I don't do at this speed though, for people wondering. So once I'll stain the cornea with trypan blue, wait for the corneal staining to happen, and then you can see in the light off, please. You can see that the deceased cornea gets stained well with trypan blue, and after injecting the IOL under viscoelastics, I mark the central 4 millimeters of the cornea. Use a reverse Sinski to do the scoring. So always make sure that you do a very gentle scoring. You don't want to scratch the stromal layers, and you can have fibers that come out when you do a deep scratch, which can again cause scarring. So do a gentle scoring of the desmetorexis. Some surgeons, I've seen videos where they just do the scoring, use a forceps and then complete the desmetorexis. I like to score it well. Use a forceps and remove the tissue. It's a very straightforward surgery. So in our experience, we've done about 6 cases, and all the patients have had a minimum of 18 months follow-up. Out of these 6 patients, 1 patient did not do well, and we had to go ahead and do a DMEC in him. So one of the patients where the pre-op vision was 660, and the best corrected visual acuity was 612 pre-op. With Fuchs endothelial grade of 2 and cataract of NS2. So this is post-op day 1, where there is minimal corneal edema is there, and patient has 624 vision, and you can see the ASOCT showing very thick corneas of about 900 microns. So here patient counseling is very important, because you have to tell the patient that you're not going to see well for at least a minimum of 2 to 3 months, and you should also counsel them enough. And they should be ready enough to get another surgery done later, DMEC or DSEC, depending on what you want to do. So patient counseling is very important here. And this is day 30, where you see that the corneal edema is gradually coming down. And this is 3 months post-op, where patient has 6/9 vision. And 1 year post-op again, 6/9 vision. So, and the corneas have really cleared well. Patient is quite happy. This is the case where patient had pre-op vision of 5/60, but this patient, the cataract was slightly on the higher side. It was about NS3. And we don't know if that was the reason for the edema not resolving. Again, a few number of cases for us to come to a conclusion. And 6 months post-op, patient still maintained at 1/60 and the edema was not resolving. So we went ahead and did a DMEC and patient improved to 6/9. Thank you.
Thank you, Divya, for paucity of time. Because of paucity of time, maybe we have to have the discussions one-to-one later for the speakers, though all three talks are very important and very interesting, newer topics. Sorry.
Dr. Lakshmi Mahesh, are you there in the auditorium, please? Can you come to the thing?